According to the latest data from the Victorian Cancer Registry, for people with pancreatic cancer living in the southern Melbourne region, the 5-year survival rate is only 10%. That's pretty grim. Up until now, there has been no locally accepted common definition of borderline resectable disease for pancreatic cancer in Victoria. To put this in lay terms, some tumours are really tricky to remove, and it's largely up to the surgeon to decide whether or not to proceed. Some will, some won't. The lack of documented and agreed common criteria to define resectability is a barrier to determining appropriate treatment for pancreatic patients. But there has been a new development in the way surgeons define borderline resectable disease, which may open up further possible treatment options for patients. Two of the lead clinicians in this exciting new project are Dr. Charles Pilgrim and Associate Professor Samantha Ellis. Dr. Pilgrim, you're a hepatobiliary surgeon and one of the leads on this statewide pancreatic cancer project. Before we get into the details of the project, can you tell us what exactly is the function of the pancreas and what are the usual symptoms of pancreatic cancer?
The pancreas is one of the important digestive organs. It sits deeply situated in the abdomen. Its two primary functions are in the production of insulin and some of the hormones that go into glucose metabolism, and it also produces a number of the digestive enzymes which we use to break down our food. Pancreas cancer most commonly presents as the patient going yellow and jaundiced, and following that obvious change in colour, patients present to their GP and liver tests ordered as a blood draw show an obstruction to the flow of one of the digestive enzymes. Following that, patients undergo scanning, often ultrasound and ultimately CT scanning, which shows the problem being a blockage in the pancreas.
And how serious is the disease in Australia today?
Unfortunately, 2/3 of patients who present, or when they present with pancreas cancer, it's already spread to other organs such as the liver or the lungs, and in those patients there's no surgery that we can offer. And in the third of patients in who we can't see any cancer that's spread elsewhere, 1/3 of them will be too old or sick to contemplate having surgery. A further third will have local progression of the disease, which meaning surgery is not an option, and therefore only 1/3 of a third, or about 10% of patients, can ever be considered for surgery. So it's fair to say it remains a formidable disease. And you've already said the 5-year survival is not great, but is improving, and there is some hope for the future.
This project, led by the Southern Melbourne Integrated Cancer Service and the Northeastern Integrated Cancer Service, as I understand it, covers the radiological component of the diagnosis. How did the project come about?
Well, I've said that 1/3 of patients don't have obvious spread to other organs, but within that group, who we say are non-metastatic, there's still a wide spectrum of how locally advanced the disease is. Some patients, the tumour is clearly resectable, and other patients it's clearly locally advanced, but there is a borderline group in the middle. And what constitutes borderline resectable pancreas cancer is an arguable point, and there are many different definitions and descriptions of what could be considered borderline.
What will be the ongoing benefits of this brand new tool?
Well, if we can agree on what is truly borderline resectable, then we can all speak the same language and therefore be able to compare results from all of the different centres in Victoria that perform surgery on pancreas cancers, and really therefore nut out what variations exist across the state. And if we can eliminate those variations, we expect to be able to increase the standard overall and improve patients' outcomes.
You use the word language. Does that mean you're doing something about the language to describe this disease?
Well, the project is to agree on a universal language and use of words to describe whether a cancer that's in the pancreas is in one of those three categories. Is it resectable, or is it locally advanced, or is it in that middle borderline resectable group? And specifically, we define that by its involvement or otherwise with the various arteries and veins that are in the area. So it's not really inventing words, it's just agreeing on using the same set of words and same categorisation so that we can standardise care across the state. The 2017 Pancreas Cancer Summit that the Department of Health convened allowed us to identify that group of patients as being an area of deficiency and not being able to really identify who was locally advanced and who was resectable. And that was really what stimulated the need to agree on a statewide definition.
This project will be piloted across 2 locations, the Alfred and the Austin hospitals. Associate Professor Alice, you're a senior radiologist and the principal investigator for this project at the Alfred site, and you have been an active member of the project working committee. What is it about this project that really excites you?
Pancreatic cancer is now the 3rd leading cause of cancer-related death in the USA, and only about 15% of patients, when they present to their clinician, are actually deemed resectable. So this project is exciting because it's actually got together a large group of doctors specialised in the management of pancreatic cancer and trying to work out a better way to triage these patients down various treatment pathways. We now found with better chemotherapy agents available, better and more aggressive surgical techniques, there's now a small subgroup of patients, another 15% or so, that now fall into a borderline category for surgical resection. And we need to find that group of patients so that we've got better treatment options and better triaging of patients. So we get together a group of specialists, we work out those definitions, decide that we're all talking the same language and using the same terminology, and devising then a synoptic report or a template report so that we can then triage those patients better and offer better treatment options and outcomes for patients.
And what has been developed through this project that's a first for Australia?
So we've developed a synoptic report. What that is a fixed template report that has multiple categories that have to be filled in by the radiologist at the time of reporting the scan. By filling in all of those categories, and at the bottom you come up then with a conclusion as to the resectability status of the patient. And this is really what the surgeon wants to know. And by getting a group of specialists together, we've worked out what is important for the radiologist, what's important for the surgeon in terms of determining resectability, and also utilising the medical oncologists' specialist capabilities as well to work out this report. And in that report, all of the information is contained to then end up with a conclusion on the resectability status of that patient, and then that patient can be triaged down the appropriate treatment pathways by the surgeon. So this is an example of the radiology synoptic report. This is one of the first cases we actually placed on the database recently. And I'll just run through the categories, which are really quite straightforward. And you can see the first category is really just the basic details of the patient and of the actual scan itself as well. You'll note here that it says that there are unequivocal distal metastases. If you do notice metastases up front, liver, lung, for example, if you put yes there, it automatically takes you to the bottom of the template report because they're automatically deemed metastatic and unresectable, so you don't have to fill in all of the other subcategories. Failing that, like in this case where we've got a no, then we have to obviously importantly state whether it actually is a dedicated pancreatic cancer protocol CT. If not, we have to recommend the patient has an appropriate CT before we actually go any further with the filling in of the report. Next group is the mass characteristics, which are fairly straightforward. We move down to the arterial evaluation, and you can see here with the details regarding the supramesenteric artery, celiac axis, and common hepatic artery. And you get some options with the drop down, for instance, is there less or greater than 180-degree arterial involvement? Importantly, arterial variance. This is very important for the surgeon, of course, when he goes in, if he's considering a resection, as to whether he needs to be aware of whether there is an anatomical variant. Venous evaluation is quite detailed. For example, if you take a look at the supramesenteric vein, whether it's involved, narrowed, and you'll see down here with the drop down that's either absent, present, you just describe whether it's unilateral or bilateral narrowing. Moving further down, additional findings. If there are some things that are a little equivocal, for instance, there's an adrenal lesion that you might think warrants further investigation, then you note it down in this sort of additional findings box. And then we come up to the resectability status. So then this is up to you to decide what is the resectability status of the patient. Is it resectable, borderline from the venous standpoint, borderline from the arterial aspect, unresectable or metastatic? This is the inbuilt logic, which is actually really quite interesting, and you can see it actually derives its own conclusion, which actually does concur with my conclusion above. At the moment we're not utilising that, and that will hopefully be something that will come to the fore later on, but we've just got that going in the background. If you're unsure, once you've ticked all the boxes in the above report, what category that patient falls under, then we've listed here very nice and succinctly in a box format what are the resectability status, and that's according to the international guidelines, and there's actually a reference to that below as well if you want to read that. And then right down the bottom, this is now filled in prior to the MDT, this template, and then we bring it along to the MDT, and after the discussion, if there are any changes made, differences in opinion, for instance, as to what the veins, the venous involvement, then we note that into that little box at the bottom, and then the whole thing then can get uploaded to the patient's clinical record. Long lasting is obviously very patient focused, and I believe now this small but very important subgroup of patients with borderline resectable cancer will hopefully be triaged appropriately, received chemotherapy, be re-imaged, and then hopefully become surgical candidates. So we're expanding that group of patients with now hopefully we'll have surgical options available to them, and therefore have better patient care and longer term outcomes.
Sounds like a fantastic tool.
It is going to be a fantastic tool.
Well, I hope you've enjoyed today's presentation. If you would like further information on any of the topics discussed today, here are the contact details for the SMICS team. Thanks for joining us. Take care. Goodbye.